Good evening, everyone. Welcome to the second edition of a new activity launched by the Jaipur Surgical Tutorial, which is being looked after by my colleague, Dr. Anand Nagar. Anand, you can come in. I'm VK Kapoor from Mahatma Gandhi Medical College and Hospital in Jaipur. And this is an online educational portal which we started about 2.5 years ago. We conduct a weekly session on every Saturday morning, 9 to 10. It was primarily started for the MCH and DNB students in surgical gastroenterology, but all the topics are obviously of interest to MS and DNB students in general surgery also. And I'm sure many of our student members are actually MS and DNB general surgery students. And as I mentioned, that this activity is coordinated by my colleague, Dr. Anand Nagar. In between, I will keep posting his number. So those of you who want to join Jaipur Surgical Tutorial, please feel free to WhatsApp him. Just send a message to him. He will add you to the group and you will get all the notifications. In addition to that Saturday morning activity, we thought that we would start an evening activity also, which is at the moment once in a month. We did the first activity last month, where we did a master class on living donor liver transplant. The format of the master class is that we do 2 sessions on 2 consecutive days, the last Thursday and Friday of a month, 7 to 9 p.m., and try to cover a topic. So last week we had a galaxy of speakers from all over the country, and actually almost all of them, I must say, were my alumni from SGP-GIMS who are now doing living donor liver transplant. And this week we chose a topic which is of interest to not only GI and HPB surgeons, but general surgeons also, which is safe cholecystectomy. And again, we have a galaxy of experts. And actually, this topic was suggested by my former colleague from SGPGI, who is now at Sakra Hospital in Bangalore, Dr. Sadiq Sikora, who is an authority, besides on so many other things, on safe cholecystectomy, and we share this passion. We also have Ibrar and Dr. Vishal Gupta, who've done a great service to the cause of making cholecystectomy safe in terms of not only lectures, book chapters, publications, but even books, which they have all written. So today's activity actually is a brainchild of Dr. Sadiq. So I would request him to moderate most of the sessions. I'll keep making some comments in between. And because it is an activity which is of interest to general surgeons, I made a request to Dr. Sanjay Jain, who's the president of ASI, and to Dr. Prabal Niyogi, who's the president-elect. Dr. Niyogi, I think Dr. Sanjay Jain has not been able to join, but Dr. Niyogi is there. He's currently at the MLN Medical College, Allahabad. And one of, again, my former students, Dr. Shabi, is a friend and colleague of Dr. Niyogi. So before we start the masterclass, I'll request Dr. Niyogi on behalf of ASI to just say a few words and formally inaugurate the masterclass. Dr. Niyogi, please.
Good evening, Dr. Kapoor. Good evening, teachers and delegates. At the outset, I would like to my thanks to Dr. VK Kapoor and to the Jaipur Surgical Tutorial to involve ASI in this very important tutorials that you are conducting. This is just masterclass. You are teachers here. I can see you're all teachers of teachers. We're taught by people like VK Kapoor and Dr. Sadiq Sikora. They are an authority on this subject, and it is so nice to see you all here on board. Of course, today you've chosen a topic which is of interest not only to GI surgeons but also to general surgeons. The idea is the prevalence of injuries in lap chole is still about 2 in 1,000, which is still a lot, I feel, because we we feel that a patient of a gallbladder just walks into your clinic, a happy patient walks into your clinic, and he goes out in a month or a couple of months as a biliary cripple, which is absolutely unforgivable. So, like, this is something that we have to take it to heart. And there are so many methods, as both, I'm sure, Dr. Sadiq, who's an expert on biliary injuries and biliary strictures, his work and Dr. Kapoor's work. We know them from close angles, being living in the same state of Uttar Pradesh, where Sadiq Sikora's was his Karma Bhumi. And of course, he's deserted us and gone down south, but we still remember him as a great teacher, Dr. Kapoor and Dr. Sikora both. So without much ado and without wasting too much time, we would like to ask for D.K. Kapoor to take it over from here. We would like to, before I finish, request to the Jaipur surgical tutorials that we would be happy to get ourselves as the ASI to get involved in such academic activity. I am the president-elect, which I will be taking over next year as the president of the association, and I would need all your support.
I think we lost Dr. Nyogi's connection, but I would like to thank him and ASI. And with that, we will start the masterclass. The first presentation is by Sadiq. I will take the liberty of introducing the first chairperson and speaker, because they are my colleagues, current colleagues. So the chairperson for the first session is Major General Dr. R.P. Chaube, who is one of the senior most GI surgeons from the Armed Forces Medical Services. After serving the army, he joined the Andaman Institute, National Institute of Medical Sciences, as its director. And after that, he joined Mahatma Gandhi Medical College Hospital even before I came here. And it was under his leadership that the MCH course in surgical gastroenterology started at the Mahatma Gandhi Medical College Hospital. And even after his official superannuation, he continued as the emeritus professor in the department. And the speaker again is, everyone please mute yourself. The speaker is Dr. Ajay Sharma, who is now my colleague and the head of the Department of Surgical Gastroenterology at my new institution. He is from SGBGI. He's one of the pioneer GI surgeons, not only in the city of Jaipur, but in the state of Rajasthan. So I would request Ajay to start his talk on evaluation of a patient with the gallstone disease. And over to Dr. Chaube and Dr. Sadiq. Ajay, please start.
Thank you, Dr. Kapoor, sir, and special thanks to Dr. Sadiq, sir, for starting this initiative. It's a very much required topic present date, and I think I hope I will. My intention for the presentation made today was to mainly serve MCH students and the practicing general surgeons. So it will have a lot of practical knowledge, and the theoretical aspect will be slightly less. So with that. Okay, so the topic given to me is evaluation of Lap Chole. If I start with history of a patient whom we need to examine, the points are very straightforward and clear, that the pain abdomen, site, the duration. But I think most of these points, if I tell to most of my residents and even the MBBS students, they will be able to tell more better than what I will be speaking. That what is it relation to the food in a patient of gallstones? It is more related to food. And it is always important what is the last episode of pain. A patient who has had a pain a day back, patient who is having a persisting pain, patient who had a pain few months back makes a difference in your surgical planning for the patient. How severe the pain is. Is it associated with fever? Is it associated with severe tenderness in that area? The patient is having shoulder pain. The classical pain is never in the right hypochondrium. It can be anywhere in the abdomen, but most common side being right hypochondrium. But understand, right shoulder, back, these are the areas which may have a referred pain also. Sometimes you may have patients which may have no history of pain. These maybe these are, but they have gallstones. They will be categorized in the category of asymptomatic gallstones or incidentally detected gallstones. Most of them are young pregnant females who have got sonography for their pregnancy and found them to have gallstones. So they may be asymptomatic. Then second thing is dyspeptic symptoms. They may not be pain, but the patients can have a symptom. These will be included in symptomatic gallstones. And this has to be typically qualitative dyspepsia. That is, a patient is having dyspepsia with a fatty food. Sorry. Then, of course, any patient of gallstone, I was being taught when I was a resident that jaundice, pancreatitis, history of cholangitis, these are important. So the patient who is having jaundice has to be more relevantly taken in this group of patients, whether he is having pigmented urine, acholic stools, that is features of obstructive jaundice. For residents, I think the pruritus, acholic stools, and pigmented urine are the characteristic features of obstructive jaundice. And waxing and waning of jaundice may be present in some of this group of patients who have a stone passing into the CBD, a fever, which may be present, which is very important, even if he has a history of stone with cholecystitis, or the patient is having cholangitis or pancreatitis. All the three becomes an important relevant history in this group of patients. Always take a history whether the patient was admitted, especially for pain, jaundice, or fever, or pancreatitis, as I have already told. With a gallstone, always keep it relevant that anorexia and weight loss are important, because many of the patients in India can have gallstones with malignancy along with that, which needs to be excluded based on evaluation subsequently. How long has been the pain? What intervention relieved how long has been the jaundice, and what intervention relieved the jaundice? And was any procedure done in the past for any of the surgeries done in the past? The medical diseases are very important in this group of patients. We often, I have found that the general surgery department often overriding the findings that the patient tells that he has had a history of GI bleed, he has a history of ascites, he has a chronic liver disease, is chronic alcoholic. Take it into consideration, because the surgery is going to be difficult if you do in this group of the patients. Any patient with bleeding disorders, that is for all laparoscopic procedures, you have to be very cautious, rather with most of the surgeries nowadays, at least the closed space surgeries, that if he is on anticoagulants. Previous surgeries, whether the patient had a post-operative course, how was it? How long back the surgery was done? A surgery was done with a fan and steel incision, has less relevance. Difficult wound healing with a right subcostal incision, definitely you have to be more cautious. A midline incision, poor wound healing, secondary intention of wound healing. I think take it cautiously, because you may find it difficult to do a lap chole in this group. Scars which are close to umbilicus or right hypochondrium or midline are always to be taken consideration of, vis-a-vis if a patient is having a left side scar or the patient is having a fan and steel incision, that may be relevant but not that relevant as for this for lap chole. These are routine investigations, routine things that we always ask, because cardiac disease, antihypertensive medications, pulmonary psychiatric disorders, and long-term anticoagulation is very important. A tender lump, take it cautiously. Palpable spleen, very important. Take it cautiously again. This may be a underlying EHPV or a portal hypertension or a CLD patient. Icterus, be cautious. Many times we get a patient who have a written performer from periphery. The patient is having gallstone related jaundice. Gallstones never cause jaundice until unless it is a Mirizzi syndrome or it is a stone slipped into the CBD. And always auscultate the lung, because air entry at the bases may signify that the patient had a ruptured gallbladder or a pancreatitis, decreased air entry into the left base, a subtle marker of pancreatitis that you should be cautious of. Let's come directly to the investigations now. These are routine investigations that we do for any fitness, that is a CBC, we would do a LFT, INR, and definitely creatine, chest X-ray, and blah, blah, blah. But with LFT, I mentioned GGT. So that's what is the importance of these investigations. I think LFT and TLC are very important investigations. If the patient is having high TLC, be cautious, he's having some infection somewhere or an acute inflammation. Bilirubin, you will find always it is mentioned the bilirubin is so much. They may not have a written report of how much was total or direct. That will give you evidence of direct hyperbilirubinemia. SG, AOTPT, AST, ALT are very relevant factors, because they inform the inflammation of the intrahepatic inflammation of the biliary tree. Implies that you should be cautious if the patient is having a significantly high OTPT. Alkaline phosphatase is a marker of obstruction of the CBD. There is a stone in the CBD or any other cause of obstruction. So increased alkaline phosphatase, you have to be cautious. Don't take it lightly. Same thing with GGT. I have mentioned in the lower part of the slide that GGT is very important because it increases in the hepatobiliary dysfunction, especially cholestasis, that the GGT is increased. As compared to alkaline phosphatase, these levels do not increase from the other sources. GGT is primary sources liver. Of course, PTINR, which is very often not considered to be a part of LFT in the reports, be cautious that you should get a PTINR. If the patient is having high INR, we have to be again worried about any liver disease that is there. You have to see whether the patient is having jaundice, is having obstructive jaundice, the pattern of bilirubin showing a non-obstructive pattern, patient is showing hepatitis, that is increased OTPT with a normal bilirubin, patient is having acute or chronic liver disease. These will alarm you for your procedure. How to diagnose now? That on the primary investigations, important thing is sonography, which is almost 95 to 98% can pick up. It has a sensitivity of 95 to 98%. Always ask these few questions to your radiologist. Ask him about the gallbladder wall thickness, whether the gallbladder wall thickness is uniform or non-uniform. If he can identify any ischemic area in the wall, if he can identify any perforation in the wall, if he can identify any collection around it, if there is a mass or polyps in the gallbladder wall, if he can see a stone impacted in the neck of the gallbladder, if there are multiple collections in the peri-gallbladder area, always remind him that CBD size is very important. A CBD stone can be detected less often by a sonography. It may be missed, but still CBD size should be always be evaluated. Liver echo texture, very often not mentioned on a sonography. If a patient is having an altered liver echo texture, implies that patient is having an impending CLD or a CLD, which will make your surgery more difficult. So you need to make more arrangements for the surgery. Evidence of portal hypertension, EHPV. I have found most common cause of a disastrous lap chole is a EHPV, rather than a bile duct injury, which can have a more prolonged relief. But EHPV usually causes a mortality in most of these group of patients if not handled by a secured surgeon, or if not managed on table correctly, because this patient will bleed like hell. Always see that patient may have a sonography report which is printed, which does not have any marking of details of liver. Ask them if they have seen a swollen liver, because this swollen liver can be a missed primary gallbladder cancer and having a metastasis over there or some other malignancy, which may impair your decision to do a lap chole. Always take precautions while doing a USG, that a gallbladder full of stones may paradoxically be hard to visualize, because this is a contracted gallbladder. Severely contracted gallbladder with a postprandial sonography, he may say that I could not see the gallbladder. So that is usually a very common mistake that you can find. A patient having gaseous abdomen, I think you have to be again cautious, because he may not give you full report about the gallbladder wall thickness. Take him in the fasting state so that you can fully visualize a distended gallbladder. If gallbladder is not showing a stone or gallbladder is showing a stone, sometimes you may require a MR. MR may be required for other diseases, but specifically if we want to see for a stone disease, it will be seen on T1 intense image, T1 images on MRI. That will be a hyper intense area. A hypo-intense area is in the case of cholesterol stones. Similarly, the T2 image showing a signal called a low signal outline image. MRCP will always show a signal void, which may be missed normally on a sonography to see a CBD stone or a gallstone which has not been picked up early. Now, if you have got a sonography report, how to proceed after you have got a sonography report? This is just a minor, with my experience, what I mentioned, maybe some of the things we can be overlapped or can be corrected subsequently. If a USG is showing a suspected CBD stone or an impacted stone or a surgically obstructed jaundice, or you see a dilated CBD without a stone with a normal alkaline phosphatase, get a MRCP done always. USG showing some area of swollen liver, get it confirmed by a CT scan or a MRI of abdomen. If USG is showing a suspicious malignancy or a polyp of gallbladder large size, patient is having pancreatitis, recent history of pancreatitis, recent past history of pancreatitis, patient having gallbladder perforation, patient having a previous surgery being done which is having a prolonged course, get a CT scan done prior to doing a lap chole, because this will aid you in seeing what are the adhesions, how is the collection, how bad will be the abdomen. It will give you a glimpse of that. If you have got a USG which is showing chronic liver disease, portal hypertension, always get an endoscopy. That will show you how much is the portal pressure and if there are esophageal varices present or not. A USG showing a suspicion of stone. A suspicion of stone. This was a recent information to me. One of my colleagues told that color Doppler can show a surge in the gallbladder. We have never got it done, but definitely color Doppler can be helpful. Or if your USG showing a lesion in the ampulla or a CBD, get a EUS. Endoscopic sonography is a better investigation for showing. If I'm running out of time, please let me know, sir, Dr. Chaube sir and Dr. Sadiq sir, if I'm running out of time.
Yeah, I think another 2-3 minutes maybe.
So USG, then you have to get a EUS done for that. If USG showing a lesion in the mid or the lower CBD, a cholangioscopy is a very good investigation. Definitely MRCP may help. And if USG showing ascites, definitely CCT and aspiration of fluid for the evaluation is always very important. So you may find very often these findings, this is by experience that some of these things may be present, and how you have to proceed and subsequently evaluate. Don't jump onto the lap chole because you have seen a gallstone on a sonography. So for a pancreatitis, we often prefer that CCT is a better investigation. For a CBD stone, MRCP, malignancies, again CT scan. For a portal hypertension, first is upper GI endoscopy, subsequently CT scan can be done. No stones are seen, then EUS. Sometimes MRCP or MRI can be used, but if no stones are seen and you have a history of recurrent pancreatitis, get evaluated because most of these patients will have sludge in the gallbladder. A colorectal cyst better evaluated by MRCP, ampullary region by side viewing endoscopy and CT scan, mid CBD stricture by cholangioscopy, multiple periportal nodes. This is very often finding. You will find large nodes in the HDL area, get it evaluated by a CT scan and by a EUS, which can target a FNAC from that area before jumping onto the cholecystectomy, because you may have a large node in the which is called a cystic node, and which may make your surgery more difficult if it is tubercular or if it is a lymphoma. A chronic pancreatitis, always get a CT or MRI done before jumping in for a lap chole. Pre-op ERCP, this is just an additional factor. I'll just point few things that if the patient comes. Today, I had a patient who had come following a ERCP, which was done 8 months back. So I wanted to add those images right now, but because of shortage of time, because I have seen him just half an hour back. So this ERCP, a patient who has undergone a ERCP, a patient who has undergone a ERCP-induced pancreatitis, the timing is very important. Don't hurry. If you have done a ERCP today, no hurry to do a lap chole today. Wait for a day. Let the patient settle. If the patient is having pancreatitis post ERCP, just wait. Don't just rush. Once the patient is settled, we can do a lap chole, but it has to be done before the patient is discharged. In a severe pancreatitis, similarly, wait for the patient to get settled. Don't run by amylase or lipase values. But if the patient's abdomen is settled, you can do a lap chole so as to prevent his or her recurrent episodes of pancreatitis. The tests which are often mentioned but not required are repeat paraoperative cholangiogram. This is not required. Intraoperative cholangiograms, which was discussed in between for a long time, it is not required as a routine unless you need it for a specific procedure. But mind it, if you need to have a habit, do it sometimes before going in for a difficult case. And a HIDA scan, which is no more required nowadays. This is a long algorithm, which I think I don't need to go into the detail. I would like to thank my two teachers, Dr. V.K. Kapoor, who is a teacher of all, and who has been a teacher for us, and Dr. Sadiq Sikora, who is all-time teacher till now for all of us. I'd like to thank both of them to give this opportunity. I have been trained under them at SGPJ Lucknow, and I would be happy if I can answer any of the questions.
Dr. Chaube, sir. Anand, come in. I think we've lost Sadiq. You can take over. Sadiq, please.
Yeah, thank you. Dr. Chaube, are you here?
Yeah, I'm here.
Yeah,
Yes,
please
Dr. Chaube,
go
sir,
ahead.
your comments.
Yeah, thank you, Ajay, for such a eloquent and a very comprehensive coverage of your topic in a time allotted to you. I think the topic selected, thanks to Professor Sadiq and Professor Kapoor, is a very important one. Safe cholecystectomy. As all of you know, that it is the commonest abdominal surgery being performed across the globe. And the incidence of post-cholecystectomy bile duct injury has not decreased despite so much of expertise. As a matter of fact, it has gone up a bit. So this topic is very relevant, and Ajay has covered the topic very comprehensively and in a very nice way. My just advice to the all general surgeons is kindly give adequate importance to the ultrasound. Just read the report, and if you are not satisfied with the report, kindly consult the radiologist and you can repeat it, but you must have adequate information. That is, before the ultrasound is the history taking and the examination. The history taking and examination are very important. So, emphasis must be given to the history, as Ajay has told. So, all points are very important, and I think with this, I will close my comments.
Thank you, Dr. Chope. Thank you. Ajay, very nice presentation. There are two questions on the chat. First is by Jayanta Bhaumik. What is the indication for cholecystectomy in asymptomatic cholelithiasis? Can you briefly just list this?
Sir, asymptomatic.
Sorry. Before Ajay answers, let me make it clear to the participants that's a separate topic in itself. So it would be very difficult for anybody to answer that question. But Ajay, yes.
Yeah, I think a very good question, because asymptomatic gallstones are very frequently encountered. And if we see any patient who comes to me with the asymptomatic gallstones, I always tell them to be in close vigilance. And if you have symptoms, you can come for a cholecystectomy at any point in time. I am available 24/7. That gives them a confidence that yes, in case they have any pain, we can tackle it. But there are specific indications for asymptomatic gallstones to get operated, because very often I get patients who are going to US, suppose, and they don't have a insurance where they can get a lap chole done at US, in case they have symptoms over there and they are going for a long time. Actually, in books it has been mentioned that if you are going on a long travel, or you are going into an area where you don't have a medical facility available, get your gallbladder removed. That is safer method. Or anything that, suppose a patient who's having asymptomatic gallstones, you are doing any abdominal surgery, you should do a lap chole with it simultaneously. Any patients who is having asymptomatic gallstones going in for a chemotherapy, mind it, these patients are more likely to have complications. So, and some of the books mention a stone more than 3 centimeter size. I don't agree that asymptomatic gallstones alone. But unfortunately, yes, I have had experience, 2 patients soon in last almost 20 years of my experience, I had advised them not to undergo a lap chole, and they had come with a mass in the gallbladder. And which has made, I've told Dr. Kapoor few days back only, I think it's hardly a month back, when I told him that now I think should I start doing asymptomatic gallstones as a routine. But still I don't have the courage, because there's no link between the gallstones and the malignancy. So telling them that they may have a malignancy is a wrong way to tell that they should undergo a surgery. But definitely it is not a risk factor, but they can develop symptoms. So there's a huge list of that.
So
Dr. KJ Singh also.
Ajay, the follow-up question on that is that about diabetic patients. And I just want to emphasize that that's a myth which goes on, that patients with diabetes should have their gallstones removed. So that is not an indication. Similarly, the porcelain gallbladder used to be an indication, is no longer an indication for removal just because it is asymptomatic. Let's take up some other questions. And as a matter of fact, I also wanted to emphasize that I think you have addressed one thing very important, which is ultrasound is not just about gallstones, but there are a lot of other things which we need to look at while we recommend patients to undergo surgery. And you have covered it beautifully. KJ wants to ask a question, and I also reiterate that what is important is, how about the timing of these tests? That, what do you expect? How recent these tests should be? And is there any importance of that in terms of taking a decision?
Yes, I think that's a very valid point. Actually, I had mentioned it in the time factor for a history, but time factor for investigation is equally or rather more important. Very often we get patients who has got a sonography 3 months back, and patient wants to emphasize, I don't want to repeat it. I think that's wrong. Get it right now. And a LFT, that is also equally important. If you have a LFT and a sonography done recently, within we usually prefer within 7 to 10 days. But if he has a longer duration, long back than sonography and LFT, I don't think that I would agree to it that we should continue with the lap chole on that, because the patient can have a fluctuation. If the patient is absolutely symptom free during this time, maybe sometimes we can, but I think 95% of the time I don't have. I would repeat.
I would say that if patient is having persistent or recurrent episodes of pain, then it is wise to get it immediately prior to surgery, especially LFT and an ultrasound, because that will give you a little more information. Otherwise, I think a week or 10 days or even a month, if the patient is asymptomatic, should be fine. One interesting question here is by Kaushik Bhattacharya. Is there a role of routine MRCP in patients undergoing cholecystectomy?
No, there is no rule of a routine MRCP. MRCP has specific indications. I think I mentioned that if the patient is having a dilated CBD, suspected CBD stone, increased alkaline phosphatase, you suspect a cold cyst or a cold stone into it, then, and sometimes I think we have slightly expanded our intent to do MR. Sometimes the patient is having no gallstones, patient is having pancreatitis. We often get a MR done to establish that there is a slip in the gallbladder, because earlier it used to be Metzel test, which is a non-practical test. So easier investigation is EUS or MR. So I think that is one indication which is not commonly used.
So his concern was that, missed CBD stones or CBD stones which are asymptomatic, which may be in 5 to 10%. Post-operatively, if they become symptomatic, it may be difficult for the surgeon to deal with. That's his argument. So, I mean, I agree with you that we don't do routine MRCP. There are some, surgeons or groups which are recommending doing a routine MRCP so as to identify the anatomy prior to cholecystectomy. But I think it is too much for too little benefit at this point of time. And routine MRCP certainly is not the option.
I think there are some questions above this.
Yes. How do you deal with, so this is Dr. Vishu. How do you deal with cholelithiasis in pregnant patients? Now, it's a long thing again, as Dr. Kapoor mentioned, it's a topic in itself, pregnancy, but briefly, in asymptomatic or detected during pregnancy and symptoms during pregnancy. A lot of times I get patients referred by gynecologists saying that we are planning a baby and I have gallstones. Should I get it removed?
I think the answers to this are if a asymptomatic gallstones, we don't remove them if the patient is getting pregnant, because they may have symptoms, they may not have symptoms. But if the patient is pregnant and you have a gallstone, patient can have pain related to gallstone or unrelated to gallstone, but we usually consider it to be related until unless proved otherwise. And best time is to go into second trimester. If the patient has had a smooth second trimester, no pain, in the third trimester, definitely it is a difficult time to do a laparoscopic cholecystectomy. We prefer that the patient let her get delivered, and after a month or so, we will like to have a cholecystectomy done in this group of patients. If the asymptomatic patients with pregnancy, yes, definitely there is increased chance that the patient can have symptoms. We have to explain that itself is not an indication for a laparoscopic cholecystectomy.
Right.
There's another one about Miridzi.
Pardon, sir?
There's another question. Jayant Bhaumik wants to know what are the indicators for Miridzi syndrome clinically and on ultrasound, and I would add LFT also.
Miridzi is actually, the definition of Miridzi explains everything. The Miridzi is a patient of gallstone having obstruction in the CBD causing a obstructive jaundice. So if the patient is having gallstone, which has not yet gone into the CBD, patient can have a gallstone with a CBD stone. That is a different era. But a stone impacted in the neck of the gallbladder, causing an obstruction over there, which can erode into the CBD partially or completely. That will lead to an obstructive jaundice. So the patient should have jaundice, which should be obstructive in nature with an increased alkaline phosphatase and a GGT and a dilated IHBR proximal to it. So that is the basic thing that is required with a stone impacted in the neck. That is the critical part. So that compiles the complete Miridzi syndrome.
I think Dr. Chaube sir wanted to say something.
Yeah, just about the asymptomatic indication of asymptomatic routine cholecystectomy. I think certain professions, particularly the fighter pilots, because fighter pilot flies the plane alone, and if he develops plane, it's a disaster. and also the naval people who are going on a long stay, boys, or even the marine people who are on a long voyage. I think there one can consider the cholecystectomy in a asymptomatic gallstone.
You may make some concluding remark and then we will move on.
Actually, Dr. Chaube, I agree with you. A lot of the, even pilots, actually, they need a fitness. And even if they are asymptomatic gallstones, they are required to get it out. But I think this is, in my opinion, this is a very important aspect of going in for a cholecystectomy, is to understand what are the things around the gallbladder which may determine the outcome. And Ajay has covered this beautifully. So the key points are: history is important, symptoms recurrent, liver function tests always see very critically, ultrasound should be done by an expert or somebody whom you know, that you would provide you with all the information. And I personally don't accept any ultrasound as enough to diagnose gallstones and carry out the surgery unless I have all the information which Ajay has listed. And finally, you should be able to define the next step after an ultrasound based on what you find on that. And Ajay has also listed that. I think it's a brilliant start to this, to get this perspective of gallstones. Thank you very much, Ajay. And Dr. Chaube, thank you very much for sharing this session. We'll go in for the next one. Dr. Kapoor?
Yeah,
Thank you.
So I see Professor Mo Maint from Myanmar has joined. Welcome, Dr. Maint. I hope that we will have more collaboration between Burmese or Myanmar surgeons and Indian surgeons, and I welcome you to this masterclass. Thank you very much. I would be happy if at any stage you would like to make a comment, just please put it on the chat. I also see so many other senior persons. I'll identify and name them in between. So we move on. Thank you, Ajay. We move on